I'm going to talk about surgery because that's what I am and that's what I do. And I've been working overseas a long time, and it actually didn't dawn on me for a very long time till we were actually doing a different study that we weren't seeing a lot of women in the hospital outside of maternity wards. And why was that? So that sort of kind of became an area of interest. It's a difficult area to study. It's a little frustrating. So we know that in health in general, there are absolute gender and racial disparities here in the United States. We know that people have various rates of cancers. Treatment, we tend to see it mostly based on income status and race in the United States. And even in the VA where healthcare is paid for, so you take the money out of it, you still see some disparities there. One of the places it's been best studied is in coronary artery disease in women, it does happen. Everybody thinks of coronary artery disease as a man's disease, but women actually do have heart attacks. And there's this whole thought that as physicians, we have innate preferences, biases, and there's these unconscious biases. When you look at the data on acute coronary syndrome, this was actually published in 2016. This is almost 30,000 patients, so this is not a small amount of patients. And ACS is acute coronary syndrome. This is the worst kind of heart attack you can have. This is a little bit better type. And in every single place, women are less likely to get the interventions that you are supposed to get when you show up with chest pain or these changes. Substantially less. And when you look at it, women are getting no intervention at a much higher rate. So why is that? Well, it's not really chest pain you're having, sweetie. It's reflux disease, right? All these other things. So this has been pretty well characterized. And when you look at, we saw a slide this morning or earlier today with this, and I kind of look at this as surgery really falls into, and women falls into these areas: good health, well-being, gender equality, and reducing these inequalities. And this is really what I've been interested in looking at. And 2012 was the last time HCUP put all this data together. In the United States, these are the most common operations that you see both for men and women. Men do have more heart disease, so you're going to see that. I love it, we're getting older, our knees, our hips, all those parts are going, right? Bad backs. And women have obviously more hysterectomies than men do, just like men have more prostatectomies than women do. So this is what it looks like in the United States. When you look at low-income countries, and this is actually data from Africa, the surgeries look really different. Much more common things like hernia. These are sort of the elective things. Cesarean section is probably the most commonly performed operation. And so it's a little bit different. You're not seeing hip replacements coming up as such a high thing. So it's a different place and time. So we know that access to surgery is a huge problem. The reason is that nobody up until about 2015, when the World Health Assembly actually said that surgery is part of essential health, had really thought about it. It's too expensive. There's been all sorts of things, but surgery was never part of a health package, even though you can't have health of a population if you don't actually have access to surgery. And on these heat maps, the brick red is the areas where there's the worst, and that's sub-Saharan Africa and Southeast Asia. Those are really the biggest areas of deficit. So are there gender differences in these utilizations? This is really complicated because disease prevalence really changes this. So when you think about trauma, in the United States, men make up 75 to 80% of trauma. Okay, for a variety of reasons, except when you start getting to the elderly, because now, as we age, we fall, and that's also trauma. But traditionally, trauma is a male preponderant disease, just like heart disease. Inguinal hernia, 1 in every 4 men will have an inguinal hernia. Women can get them, but not to that degree. cesarean sections, hysterectomy, breast cancer. Men can have breast cancers, but clearly this is a much more prevalent disease in women. So this becomes very difficult as you start looking at it, because what is a gender-neutral surgery? How do you begin to look at, are women and men having access to gender-neutral surgeries at the same rate? There's a lot of factors, and I should maybe change it to the word intersectionalities. Would that be? Women are caretakers of the family. They can't actually leave. And when we started working with one of our partners in Sudan, it wasn't just about the family. It was like, how many animals are they taking care of? And I'm like, I'd actually never thought to put that on a survey. How many cows, camels, whatever. But it is part of what the role is. The lack of resources for transportation. You have got to pay some to get someplace. Do you have access to money to pay? You have to pay for services. Most of healthcare in these areas is pay to play, no money, no care. So can you actually access money? And most of the access to money in these areas is crowdsourced. You're getting it from families, you're getting it from other people. So is it because women have less value? When's your value? Is your value only when you're in childbearing times, and as you age, you don't have value? So what's the value of woman in society? These are all factors that could happen here. So how do you get this data? If anybody knows, please come and tell me, okay? So there's hints of it. So this was a study that got published in Ethiopia. There's a local area, about 1 million plus people, and the government and Italy partnered, and they started making a referral hospital. They opened it originally, it didn't have that many beds, and it more than doubled over the next 15 years. They actually prioritized low-income people. They gave some care for free. They gave maternal and neonatal care for free, which is actually fairly common in a fair swath of countries. And then they had 100,000 plus records to look at. What do you see? So they did male and female ratios. So injuries, as I just told you, men are much more likely to have injuries than men. So that one wasn't surprising when you see a male-female ratio here. But these other diseases where you really shouldn't necessarily have a gender difference, you begin to see some of these gender differences. And so let's look at it a little bit more. So they then looked at who was in the hospital by what age group. And this is a fascinating, this thing is really not working incredibly well. This is the one on the, what side is that, left? Is really interesting. And if you see, women are in the hospital when they are of reproductive age. Men really sort of have, you know, people are dying, but as children they're there, but the big peak there is in reproductive age. And Marcia is going to give me a better pointer. A try, okay. Then on this side, this is graphing, thank you, male and female ratios. And you can see here that it's actually favoring women, except they should be equal. That's the crude male to female. What happens if you take out reproduction, pregnancy and pregnancy-related complications? All of a sudden, women are falling out here, okay? Okay, pediatrics we've been talking about. Mosquitoes have no gender preference. We actually, all the data saying that they bite women more has actually been debunked. So we're all at risk for mosquito-borne incidences. So this was a study that was done in Yemen, 2 different sites. Fascinating here, both 60-40. This was admissions for severe cerebral malaria, right? This is like or severe malaria in a whole. So what does this really say? This incidence should be pretty equal. Well, there's fewer women coming, fewer girls. These are children, because you would think, okay, children, we want to save children. There's a higher mortality rate, substantially higher. So is this a delay in presentation? What's going on here? You can't say. There's no causality here, but what's going on? So looking in surgery. So there was a group, this was done by medical students around the world, for a 2-week period of time in high, middle, and low-income countries. They did a 2-week data survey collection, just any operation coming in. And it had to be abdominal operations, and you could have no cesarean sections, okay? So we're finally trying to get away from some of the gender differences here. They weren't actually looking at that, but this is, you know, what I took out of it. So what you can see here is as you go from high to middle to low income countries, women begin to fall out. And getting into this number here, somewhere between 25 to 35% is about what you find when you start looking at this. And you could say, well, they're doing all those emergency surgeries because of trauma, right? Trauma is very common in areas. But you can see these numbers, you cannot explain these differences by trauma alone. Something else is happening here. The paper wasn't even about this, but when you look at the data, it really lends credence to it. So, there's another study that just actually published, this Africa surgical outcome study. The countries all in green participated. This was a 7-day prospective cohort study, and it looked at, you had to be in the hospital at least one night, and it was both scheduled and emergency surgeries, 23 countries, split between low and middle income, 11,000 patients. An amazing amount of the surgery here, 33% is C-sections, 11.5% GYN. And when you look at it, again, this around 30% number, only about 30% of the operations on women were not related to OBGYN. And one of the really scary things that came out of this cooperative is in Africa, women were 50 times more likely to die after a cesarean section than they were in the United States. So a lot of room for improvement here. So this is one of the first studies that we did, and we were trying to understand why would somebody, if you needed an operation, why did they say no? So this was done in a rural faith-based hospital in northwest Cameroon. You basically had to pay a fee to see the doctor. You have to actually get there. It's not really close to anybody. It's known in the whole country as a place where you could get very good services, better than you could get many other places for a decent price. And what we did, the doctor sees the patient, they decide whether or not they need an operation, they write it in their little book, they then go and talk to the nurse, and the nurse says, the doctor says you need an operation, would you like to have an operation? They say yes, they say no, and then you pay a deposit. And they have a whole price sheet, which kind of covers everything. So it's a system, that's how they do it, and it seems to work there. So you have to pay this deposit. So we interviewed people before they went into the clinic, and then we came in afterwards. We actually teamed up, it's a faith-based hospital, we teamed up with the pastoral service. So that was the person actually helping our student do the interviews, because in this setting, that was actually, it got much better compliance. What do we found? 1 in every 5 patients refused surgery, even when they had driven more than 5 hours to come there and paid money. So why are they refusing? Okay, sort of some demographics. This is a rural-based, mostly agrarian, so they're making about $50 or less a month. What big surprise, the number one reason that they said that they were going to refuse was because of the cost. But when you start really looking at the data, what do you see? You see gender and the source of payment as the most significant reasons why people say no. Women said no. And this ability to, what we're calling crowdsource that funding. How can you get that funding to be able to do this? This resulted in the no's. All right, getting this data, tough. So I said, well, you had to pay money. Could we look in a place where all care is free? Take the money out of it. So Doctors Without Borders, MSF, if you can get to an MSF hospital, you get your care for free. And we wanted to look at it in surgical areas and conflict zones, because when you're in conflict, the health structures are basically disrupted and you really don't have access to other types of hospitals typically. So this was one of the 5 operational centers from MSF. We looked at all of their procedures. It's broken down by different things. And it's important to know that even though you say you're in a conflict zone, the vast majority of operations you're doing are for the population with regular problems. They come in with appendicitis. It's not that they're getting blown up. So these are the red areas are where this data is coming from. So you can see sub-Saharan Africa, Afghanistan, Pakistan are the basic areas. So we took 100,000 interventions. By the time we got through all of them, we didn't want to look at disasters. That's like an earthquake hits or something. It's a very different question. So we ended up with close to 50,000 patients that we could analyze. Huge amount of stuff to look at. You could look at where are they, so you can see the spread of countries here. We looked at WHO regions, GDP being spent on health, literacy rates, dominant religion in the country. You can analyze this data very many different ways. And then you can break it down by trauma versus non-trauma. So violent trauma is things like bombs, guns, knives, rape, torture, right? Somebody doing something to you. Nonviolent trauma are things like burns, accidents, falling out of a tree, cars, things like that. And as we said, not a big surprise. Men really had much more violent trauma. But it's interesting, bombs are not discriminating, right? They're kind of like mosquitoes. There's no gender neutral. They are gender neutral. They drop them. But when you look at who was coming in with injuries after bombings, it was predominantly men. Burns, very common in women because women tend to be doing cooking. That's not unusual. We then looked at what we call the non-trauma, so other diseases. And outside of abscesses, men, again, were showing up with at a much higher frequency. So all of this, what did we find? No surprise, men had more operations because of trauma. Men were almost twice as likely to have surgery in countries that were predominantly Muslim. Women were much more likely to require surgery because, as a result of a traditional medicine practice. And the data actually, as analyzed, underrepresents the actual thing because you could get counted for every operation in here, and women had to have more interventions than men. So again, we see a signal. We can't talk about causality or any reasons. So you can't explain this, though, by the disease demographics. Okay, we move to a different country. You got to go to where you can get the work done. So here we're in Malawi. And we're looking at, again, emergency surgery, general surgery, and looking at who got peritonitis, infection of the abdominal cavity, except for gendered pathologies. So we took away trauma, we took away OBGYN, we took away hernia disease, because they have prevalences. And in the US, this is actually women have more emergency general surgery than men do in the United States. And what we looked at, what was the time to presentation and then the time to operation at this hospital that's in Lilongwe. So total group, just over 450 patients. Look at this number popping up again. It's this number this 30% number just keeps, we see it almost every time we start looking. So again, more men showing up. And then what was really interesting here is that men, time to operation, substantial differences. This is peritonitis. That's an emergency. Men getting to the operating room much more quickly than women. And so fewer women are coming. They have delays, longer length of stays, and less operations. So again, sort of story. So why? So my current area of trying to figure this out is why. I'm not really sure how to figure out why. So we actually started doing some surveys, and we have Diana here who's going to be doing one of these surveys in a middle-income country this summer in Africa. But we actually went into Malawi and did some surveys. We adopted some surveys. And one of the questions that we're looking at is, who do you prioritize for medical care? You can prioritize yourself, your spouse, your son, or your daughter? And this is a gender equity survey. There's all sorts of other questions. But what really, it surprises me, but it doesn't. Women prioritize their sons first, their husbands second, and their daughters last. And if you think about it, we see it in our own health behaviors here. Many women make sure their husbands get their colonoscopies, but they're putting theirs off. Women sort of, in many ways, do look at the health of the family. It also might help in interventions as to sort of saying your health is also important. So all this data, I think, is telling a convincing story that we need to keep looking at even more, which is there is a disparity in utilization of surgery in low-income countries. Middle income, I think it's there. We're going to get a little bit more data on middle income. It looks like it's almost a dose-dependent effect now, depending on whether you're a high, middle, or low-income country. I think, you know, we can't, as a surgeon, how you even figure out what the factor is, I'm going to have to, that's a hard question. But clearly it's societal, cultural, economic. There's a lot of things that are going to go into this. But I think if we don't understand this, we cannot reach gender parity in health. I mean, we just can't. If women don't have access to the same type of surgical care that men have, you're going to have dead women, disabled women, and again, the health and wealth of a population is really at risk. So that's my last slide. I'm happy to take any questions if anybody has one, but thank you.